think it's here. One microphone. All right. Yeah. No, I'm okay. Okay. Let's restart. This is a talk that belonged to the previous session, but so PCI in patients with congestive heart failure. So this is a tricky subject, and you will see why. So I will show you two cases first. This is a 58-year-old gentleman. He has no previous history of cardiovascular disease. In theory, he was a healthy person. He has risk factor, was a smoker, but no other risk factor that he was aware of, at least. Patient went to the emergency room because of shortness of breath for a few days, then night chest pain, and during the emergency room evaluation, his blood pressure was borderline 100/65. Heart rate was on the high side. The oxygenation was correct, was normal. Chest rate shows an enlarged heart and mild pulmonary congestion. EKG did not show any significant changes. And the BNP, the BNP was 1,300, and the troponin was 2,000. We repeated the troponin, and it was around 2,000 as well. So it was a kind of flat curve. So when we did the echocardiogram, we found this on the echocardiogram. And you see that the ventricle is enlarged and it barely moves, 20%. So as part of the protocol of evaluation, we did a heart catheterization, not thinking that we're going to find any coronary artery disease, but we did find that it has a complete occluded LAD, completely occluded OM branch of the circumflex with collaterals from the right to the LAD. So we thought that there was an ischemic cardiomyopathy. We didn't know when this started, based on symptoms not a long time ago, but based on the size of the ventricle, it looked like it was longer than that. So we consulted the surgeons for bypass surgery, and the surgeons said, I don't know if I want to operate on this guy. I don't know if we're going to do something good, so let's do a viability study. So we did a viability study, and the viability study shows that the LAD territory was not viable. There was nothing to save there, but the other territories were viable. Though the patient was considered non-surgically because they are going to do a surgery just for an OM branch of the circumflex. So what do we do? So most would have said, well, let's do medical treatment. And this patient is a ischemic cardiomyopathy, but he's already with no options. So the patient was put in medical treatment, and he barely tolerated any medication. Blood pressure with lisinopril only 2.5 milligrams was in the 90s. And I was looking at the pictures, and I said, well, this patient has a very thick heart. There is no the usual remodeling yet, as well as the EKG was too normal to me to say that this patient had a heart attack. So I decided to, it's kind of weird, this, okay, here. I decided to go ahead and revascularize the patient. So I did the CTO of the LAD in the first study, so we put a wire in the circumflex for stabilization. So I opened the LAD, and the LAD, as expected, is a kind of not great vessel. I put a stent across the diagonal, and we had this more or less result. I decided to do an IBUS to optimize, and I have this result. I decided not to do anything on the bifurcation. The diagonal was open. There was diffuse disease, but it left it alone. So I brought him back a few weeks later, and I did a PCI to the CTO of the circumflex. But I took a picture, and you see how the LAD is much larger now, is much more robust, as well as the diagonal is a very sizable vessel, although the timid flow was perfectly preserved. So I didn't do anything that. I opened the CTO, the circumflex, and I have a good result. And with that, we continue with medical treatment. And 6 months later, we did an echocardiogram, and he improved the left ventricular function. So this is a success case. But not necessarily this is the case in every patient. You see in the other projection. And you see the mitral regurgitation that was before, that it has almost disappeared. So the next case is a patient with acute heart failure. The other one was a patient we thought that it was chronic. But this one is a 26-year-old kid that has certainly no previous history. Risk factors, he is a smoker, no other known history. Comes with a chest pain that was crushing chest pain. He was also kind of weak. And the EKG saw 4 millimeters C elevation in V2 to V1 to V4, as well as some ST elevation in lead 1 AVL, and the inferior leads were not reciprocal, was some ST elevation. Blood pressure was 80/40, and heart rate was 90. So certainly that was systemic. We took him to the cath lab, and we found something that is sometimes happen, that you have a 2 vessels occluded at the same time with very large thrombus burden in both vessels. So in this patient, we put an impeller to begin with. Then we open the LAD. Aspiration, you see that we don't have that much of the flow in spite of aspiration. So more aspiration and balloon and drugs distally. Patient went into heart block. We had to put a pacemaker. So this is the final shot on the LAD, and I didn't put any stents, and you don't see any lesion, but you do see the distal flow is not the greatest. Then I switch over to the right coronary artery. I open the right coronary artery, and you see a lot of clot everywhere, distal embolization, aspiration, more balloon, more aspiration, and you see we got flow, as good flow. I did not put any stent. We thought that this was predominantly blood clot, and we gave aggressive antiplatelets. This was done in an institution that is a satellite place that we do intervention, but it's not a high-level place. So we transfer the patient after that to a higher complexity place. And actually, the kid went home in around a week. He did have a rough first 24 hours, but he went home and he was very successful. It turns out that there was something related with the synthetic marijuana that he was, actually we published this case because it was considered that was related to the marijuana, this synthetic marijuana that he was doing. So as I show you, you can do things, you can open arteries, and in some patients you are going to have benefit, and in another ones are more challenging to determine. We do have devices that may help us to do these procedures safer, or at least from the hemodynamic standpoint, more supported, but where is the data? And the data is challenging. It's challenging because this is a complex group of patients that we do not know exactly how to select them. So we do know that in the context of acute coronary syndromes, like I show you, there is no doubt that intervention is the treatment of choice, okay? That it is no doubt. We are not debating that. Perhaps we still do not know what is the role of the left ventricular assist device in this group of patients. We do have some data in randomized trial, but altogether there are very few patients, so still we are lacking of data and hopefully the randomized trials that are ongoing in Europe will give us some lights on that. We do not have that information yet. We do believe that they help us, but not based on randomized trial. What happened in the chronic group? In the chronic group is more challenging. So we do have one study that was just published a few months ago that tells us that coronary intervention with balloon angioplasty, it is not better than just medical treatment. So it's not better in any group selection, and it's not better in improvement of left ventricular function based on echocardiogram, and it's mildly better in quality of life during the first year, but that quality of life after 2 years, it is the same. So based on the only randomized data that we have, the patient that I showed you before, the number 1 patient, I should have not done it. So what is the answer? Well, I don't think that we have the answer yet, and we do not have trials ongoing in this particular group of patients. There are no trials that we are doing right now in patients with chronic heart failure. So based on those studies that we have, there is no reason to do this one. I think the answer is that we do not have enough amount of data. I think this is a review paper that was published recently, and you see all is question mark, question mark, question mark, question mark. And it's also question mark whether we can use viability studies even with MRI to determine which patient is going to improve. I just showed you a patient that the MRI was completely saying that there was nothing to do in this patient, and I used kind of all criteria from an old guy that he said, well, if the ventricle is thick and there is no infarct in the EKG, maybe it is viable even though the MRI said that it was not. And so we do not have the appropriate amount of information, neither the tools to determine whether revascularization is beneficial in any particular patient. So I will leave you with a question mark. We do not know which patient will benefit. So patients with heart failure are a fast-growing population, unfortunately. There is no doubt that patients with acute heart failure secondary to acute coronary syndrome, PCI is the gold standard. The role of mechanical support is still not well defined. The role of revascularization in with PCI in chronic heart failure is not indicated in all patients. However, determining the patient that will benefit is not clear currently. Determining ischemia viability and predicted clinical outcomes remains a challenge for us. Thank you.